Needlestick injury with a HIV patient, Human Immunodeficiency Virus patient. In the week, we always get a call or an intern or a nursing staff come to the OPD and say, "Sir, I had a needlestick injury, what to do?" The most dreadful, stressful situation comes if the source patient is HIV positive, HIV or AIDS positive. In those situations, what to do? This is Dr. Manoj Prabhakaran, a practicing nephrologist and physician, sharing with you ground level information and practical management steps in these clinical scenarios. First, what is the risk of transmission? Theoretically, if you take, they gave us 0.3%. If I have to put it in words, it is 3 per 1000 needle sticks. But it is not an absolute criteria. The risk of transmission from the source to the person or the healthcare worker depends on many other parameters. What are those? The site of injury, the depth of penetration, and the patient place where it got exposed, like whether it is transcutaneous, intact skin needle injury, or on any injured skin. And the fourth important one is source patient's viral load, source patient's CD4 count. These are the subtle things which decides the risk of transmission. First, we will see one by one. Needle stick injury mostly occur in these fingers, index finger over the terminal phalanx area. If the prick is deep, the risk is high. But there are some OT technician, operation theatre technician, nursing technician who handle the sharp instruments. The cut can be in the palm on the back side. Whenever the injury is near the vein, the risk is high. And another common scenario, the cannula. While recapping the cannula, deeper the penetration, more is the risk. Why there is a higher risk with cannula is a wide bore needle. Inside that blood will be there. So higher the bore and inside which blood is there is a more risk. So depends on the instrument also, which contains whether blood or not, and also the thickness. A ABG needle versus IV cannula is different. A ABG needle versus OT knife is different. So first you have to find what is the risk, highest risk or lowest risk. This is related to the exposure. Okay. Then related to the source patient. Source, from where you got the needle prick. There can be two scenarios. You know the source which is under your follow-up. At that time you can send the viral load and CD4 count. CD4 count, if it is very low, higher is the risk. These are the practical things you might not find in the text where just they say 0.3%. So CD4 count you have to do, viral load you have to do. If it is CD4 is low, viral load is high, the chance is higher. If CD4 is high, viral load is low, the chance is lesser. So let us see exposure through the transcutaneous route. It can be in the eyes, it can be through the oral area, any mucous membrane for that matter. Eyes, blood spillage. In the OT, if they are focusing on doing the surgery, during that time blood might splash. It is not uncommon for a surgeon, at least they might have get 1 or 2 splash in the face during their surgery, MS general surgery journey. While doing CSF, CSF contain highest quantity of virus in patients with HIV, so be careful while doing CSF. The fluid might spill. Not only the blood, any body fluid for that matter, saliva, pleural fluid, pericardial fluid, semen, vaginal secretion, any for that matter. So what to do if the blood get exposed on the intact skin? No, it won't be considered as a exposure. If it is an intact skin, no cut marks are there, it won't be considered as a exposure. Then coming to the management, two scenarios can happen. First, you are knowing the patient is HIV positive. Second, in the laboratories, the person got exposed to a particular blood, but he doesn't know whose blood it belonged to. Probably a OPD patient, he doesn't have any other detail, only OPD, we don't have details. That time you have to consider it could be positive. You can't leave it as for hope it is negative, no, but you have to think it could be positive. So there are two scenarios. If you know the source patient well and good, source patient even HIV status is not known, then also probably treat that as positive, retropositive unless proved otherwise. Okay, this is very common in very big district or state primary hospitals where load is very high. Then in the lab you might not be knowing the status of the blood that you got exposed to. Coming to the main topic, management. What to do? First, whether it is transcutaneous spread, needlestick injury, whatever it is, leave the job, whatever you are doing, just go and wash the hand immediately. Wash it for 10 to 20 minutes with the water. If it is in the hand, you can use an alcohol-based antiseptic. Use it for 10 to 15 minutes, wash it. That is the main thing. Okay. What to do if there is a splash in the eyes? Only water is enough. Rinse the eyes with the water. Any transcutaneous, use an ample amount of water. As I told in the hepatitis C management, here also in HIV needle stick injury, the students, many students will think, my rounds is going on, I will do that, after that I will know. Leave all your whatever the commitments there, leave, inform the colleague that you got a needle stick injury which is of primary importance, go to the washing area, start washing. That is the first one. Don't try to squeeze the blood out. Don't squeeze it. Don't try to put your hand in the mouth and try to take out the blood, which one of the student did for hepatitis C needle stick injury. That is why I was supposed to tell. I hope none of you might have tried this, but I am bound to tell here because one student have did that also. So don't do those things. Wash it. Don't squeeze. Don't give any extra pressure, because extra pressure, there are no proven benefits and it might create a back suctioning pressure which might pull it back. So better don't squeeze it. Third, especially in a medical college, there will be a committee for this post needle stick injury, especially for HIV, human immunodeficiency virus. You have to inform the committee. There will be protocols for that particular institute. You have to inform them. They will check how many this kind of needle injury came. They will be having data of the past injuries. They will be having data of the institute specific protocol. Definitely you have to inform them at the earliest. Okay, this is the third one. Fourth, most important one, drugs. Which drug to take? This is very important in AIDS or HIV post exposure. You have to take the post exposure prophylaxis drug. It have to be started at the earliest, as early as 2 hours. Earlier you take the medication, better will be the prevention. So those exposed near the vein, deeper penetration, wide bore needle, cut injury, don't hesitate, wash, directly go to that committee, take the drugs. So here a question might come, sir, I got the needle prick injury in a clinic or area where there is no committee. Don't worry, the committee will also going to follow the drug regimen only. They will assess the exposure, they will assess the post-exposure prophylaxis treatment. What first they will do is give you the drugs as early as 2 hours. If the time is delayed, the prevention that effect because of the drug also will be delayed. So take the drug as early as possible. Preferably we have to take it before 72 hours. After 72 hours, the benefit might not be there that much. That is why you have to take it at the earliest. What drug to take? Previously, there was only one drug regimen. Now, current scenario 2025 April, this video is being shot. 3 drug regimen is being used: tenofovir, lamivudine, dolutegravir. This is a combination drug is available as a single tablet. Tenofovir is 300 milligram. Lamivudine is also 300 milligram. Dolutegravir is 50 milligram. You will get it as a single tablet. Take it as early as possible, single dose. Okay. Most of the places, including India and foreign countries, nowadays this combination drug is available. Suppose if this combination drug is not available, what to do? Instead of the third drug, you take any other 3 drug combination. Tenofovir, lamivudine, ritonavir. You can take. If 3 drugs are not available as a single tablet, take it separately. If the second regimen is also not available, what to do? Tenofovir, lamivudine, efavirenz can be taken. Okay. Why I am not telling the dose of this efavirenz ritonavir? Because usually you will get the first one. Like even in India, almost all the committee in medical college will be having, especially for this post-exposure prophylaxis people. Again, I am telling tenofovir 300 milligram, lamivudine 300 milligram, and dolutegravir 50 milligram. Take a single tablet as early as possible. Okay, this reduces the chance to almost zero the risk of transmission from the source to the healthcare worker will be almost goes to very negligible. But a hook there depends on the severity exposure and the source patient CD4 and HIV count. Okay. Then next question, how long to take it? You started, you have to take it for 4 weeks or 28 days. Meanwhile, you will be following it with some basic investigation. So first, wash it. Second, don't squeeze. Third, inform the committee. Fourth, the healthcare worker started the drug for 28 days. At the baseline, the healthcare worker have to send their HIV, Human Immunodeficiency Virus status, antigen antibody. There are regimens are available, type of tests are available, either antibody based test or combination of antigen antibody test. You can send it. Not only that, you have to send your baseline complete blood count, kidney function test, liver function test. You can send at the baseline. Preferably, we tell our healthcare workers so that because the drug you are going to start might have certain side effect, to follow it up with, better to do this baseline. You are taking this drug tenofovir, lamivudine, dolutegravir, 28 days. Baseline you have sent the investigation. Subsequently, when to do? Subsequently, after 1 month, after 3 months, 6th month, almost done if the risk is very less. If the risk is high, as in the deeper penetration, source CD4 count is less, send it after 1 year also. Okay. Antigen antibody based test, whatever available in that particular hospital you can send, which is sensitive specific, you can leave out those, just send it. In between, if you are developing drug side effect which is mostly GI related, vomiting, abdominal pain can occur. I remember one of my batchmate who took this drug for a needle stick injury. Severe vomiting was there. Severe vomiting. Somehow she completed the course for 28 days. But during the 28 days, theoretically saying is very easy, but taking bit difficult. But to prevent the needle stick injury, yes, of course, that is required. Okay. Subsequently, she repeated the investigation, all found to be negative. My friend had spillage from the CSF and one more time needle stick injury. Okay. So GI symptoms might be there. So that time you might require the LFT, baseline LFT. If the risk is less, after 6 months might not be required. So these are all the drug regimen. Then what other question will come? Source patient, do you check or not? Source patient, once you know the CD4 count, HIV viral load, subsequently source patient is not going to help much. So in the post-exposure prophylaxis of HIV management, if I have to come to the summary point, the risk is negligible but depends on many other parameters. Inform the committee. The source known, well and good. If source is not known, treat it as positive, retropositive unless proved otherwise. The steps are: wash it with alcohol based antiseptic, the hand, or with plain water, soap more than enough. Transcutaneous spread can occur, use water. Intact skin, no, but you have to wash it in the intact skin. The first step. Don't squeeze. Inform the committee. Start the drug. 3-drug regimen: tenofovir, lamivudine, toltegravir. 300 milligram, 300 milligram, 50 milligram once daily, 28 days. Repeat the HIV antigen or antibody in the healthcare worker at first month, third month, 6 month, 1 year if required. Okay. So this is all information you need regarding this needlestick injury. And till now, if you are watching, I hope either you or your loved ones might have got exposure. I hope you got the info regarding this post-exposure. If you have any doubt, you can comment on this, because I tried to cover all the points, because few these kind of clinical experience and points you might not find in the text. That's why I thought this video might be helpful, because at least once or twice in a month we get a call from our juniors or any healthcare workers, sir, this happened, what to do. So at least rather than explaining them these things, so that's why this video was shot. And one more step here, a OT technician or a doctor or a nursing staff, after knowing patient is HIV positive, bravely entering the OT and doing the surgery is not lesser than the soldier who is in the war line. So my respect for you, and I hope you will come out of this needlestick injury. So I gave the information regarding the post-exposure prophylaxis. Bye bye. We will see in the next video.